rethink our approach to evaluate inhalation therapy. So what I'll be talking about is relevant changes in inhalation therapy in the past. And we all know and discussed already briefly this morning that ICS formoterol combinations on demand are, I think, a major improvement in terms of guidelines. Unfortunately, in Europe, this is not licensed and will probably never be licensed, at least not in the part that I work in. Nevertheless, this reflects what our patients have been doing all the time in the past, and I think it is a step forward. But what I will talk about is ICS, LABA, LAMA, triple combinations to induce remission, to look at which patients will profit and why we should be using them prior to biologics. And we're talking about step 3, step 4, step 5 asthma according to the GINA guidelines, where this treatment should be applied once patients are assessed, unfortunately, for severity. Now, why should we be using long-acting muscarinic antagonists in the treatment of asthma? And there has also always been small studies on short-acting muscarinic antagonists in the past, which suggested that there is an effect on asthma, but it was never very convincing until this study came out by Huub from the Netherlands, which was a multi-center study where they gave patients who were already on high-dose ICS-LABA treatment, and it was a considerable number of patients with poor lung function despite of this treatment. And this is important to memorize for later, bad lung function and more or equal to one exacerbation per year. They added tiotropium from a Respimat inhaler and looked at the time to first exacerbations, and to everybody's surprise, there was a marked effect of about a 21% reduction in exacerbations by adding this to patients who had already been pre-treated relatively high dose. And therefore, this was included in 2015 in the GINA guidelines, where add-on tiotropium down here was suggested in step 4 and step 5 asthma, before, at that time, patients were moved to anti-IgE therapy. The problem, however, with this treatment was that it was inhaled from 2 different inhalers, and it was the Respimat, for which, unfortunately, neither an inhaled corticosteroid nor a steroid LABA combination was available. And there's data, this is just one of them, showing that if you have patients on multiple inhalers, the compliance with using both inhalers is very bad, and patients basically after half a year or so are down to a 50% compliance with either inhaler. Either they stop the ICS-LABA or they stop the tiotropium. And the problem with that was that LABA-LAMA combinations are not licensed for asthma, at least not in my country, and even if ICS was used from a different inhaler, it is not according to the licensing. And ICS-LABA combinations are provided in different inhalers than the only asthma licensed LAMA, which was tiotropium at that time, which we call then the multiple inhaler triple therapy. The consequences were that we had different inhaler techniques requiring different instructions for use, as well as different dosing regimens. And those of us who take care of instructing patients know how bothersome it can be to instruct patients to use inhalers correctly, which increased complexity of treatment for both caregivers and patients. And there was, as I showed, the risk of discontinuation of ICS and or LAMA monotherapy with this multiple inhaler triple therapy. And in other words, tiotropium was licensed for asthma only in the Respimat. Unfortunately, there is no ICS-LABA fixed combination in the Respimat. And more importantly, when patients were on a pressurized metered-dose inhaler of an ICS-LABA combination plus Respimat, there was at least similar inhalation technique, which is you should inhale slowly from a pressurized metered-dose inhaler, irrespective of whether it's a PMDI or the Respimat. But if patients were on a dry powder inhaler, as there are in many centers, and also recommended from guidelines because of the less environmental effects and the Respimat, you needed completely different inhalation techniques, which was bound for errors. And therefore, we, together with Chiesi and my great friend Walter and others, we embarked on a study where we looked at the first time on a triple inhalation therapy from one inhaler, with the additional advantage of being fine-dosed or small particles. And this study is a bit complicated because it consists of two identical studies. One is called the trimaran, the other is called the trigger, with the only difference that patients in the trimaran study were on a lower dose of inhaled corticosteroids, and in the trigger study the patients were on double as much beclomethasone as in the trimaran study. Otherwise, it was exactly the same, and it was specified that the two studies were later then evaluated together. This is a bit of the patient characteristics. As usual for more severe asthma, they're in their 50s. Body mass index, interesting, it was very European and not American, which I think is important to understand the effects. And we took particular care that these patients were non-smokers. Majority of patients were non-smokers to exclude any patients that may have had or may have COPD. And in addition, patients had to have one or more exacerbations, as you can see down there. The interesting finding which makes this patient population a bit peculiar was the large reversibility, which was in the vicinity of 30 to 34% after inhalation of beta-2 agonists. Again, however, suggesting or confirming that we have been looking at asthma patients. And the results were the reduction in exacerbations or the change in lung function. And as you can see here very nicely, triple therapy, adding another bronchodilator, leads to a significant increase in FEV1 in the trimaran as well as in the trigger study. And the opposite was true, that there was a reduction in exacerbations from dual to triple therapy, which was very rewarding, and the first time that this was actually shown, and you can see this here, similar depicted as in the initial study by Groth-Kerstens, that there is a reduction in the trimaran, as well as in the trigger study with the triple inhalation therapy. The green arm is an open multiple inhaler triple comparison arm here, but compared to dual therapy, there was a reduction in exacerbations. This also was due with severe exacerbations. And therefore, the summary in The Lancet at that time, which is a few years old now, said that there was a single inhaler triple therapy improves lung function with positive effect on severe exacerbations and some benefits in terms of asthma symptoms and control. But there is, in the meantime, additional evidence of inhaled triple therapy, and others have not been lazy there. This is a study from Novartis with a single-dose dry powder inhalation therapy, and what they showed was exactly the same. There was a significant increase in lung function when a other bronchodilator, in this case, glycopyrronium, was also added, and you can see the increase in lung function with different doses here. And what they did, they compared not only the mometasone, indacaterol, glycopyrronium with high dose and the dual therapy, as you can see here, which was statistically significantly different. Sorry, this is the other. And here again, statistically significantly different. But they also compared it with seretide, as you can see down here, where there is always a significant reduction in exacerbations when compared to high-dose fluticasone salmeterol, here again, and here again. And the conclusions from that study in an editorial that I was allowed to write was that medium-dose and high-dose triple therapy significantly improved lung function, as we just saw, but there was a greater improvements in trough FEV1 and exacerbations rate compared to fluticasone salmeterol. And finally, the study by GSK looked at the Ellipta inhaler published, and they also show, with the additional interesting scientific point, that they had different doses of the LAMA added here, but also a marked improvement in lung function in all arms of this study. But unfortunately, due to probably selection reasons, they failed to show a significant reduction in exacerbations, and therefore this is unfortunately, because I think there is a class effect on this, not licensed in Germany for the treatment of asthma. Nevertheless, there is a very important for our understanding. There's a very important. This one is dead, but this one is working. But you can hear me, right? Yeah. Okay. There's a very important subgroup analysis of this study, which is very, very important to understand the concept of triple therapy and how we should be proceeding. Okay, thank you. How we should be thinking about this treatment. Because if you increase the inhaled corticosteroid, depending on the inflammation measured by eosinophil numbers in peripheral blood or FeNO levels, if you increase the inhaled corticosteroids, the effect on FEV1 is present and is especially marked when it comes to high inflammatory markers, but it's even better in terms of exacerbations, where there are fewer exacerbations when you increase the inhaled corticosteroids. The opposite, however, is true, that when you look at LAMA effect, if you add a LAMA, the improvement in lung function is relatively irrespective of inflammation, but there is not much of an effect on exacerbations. In fact, when you have high inflammatory markers, your effect on exacerbations with a LAMA is much poorer than when you have little inflammation. So I think the important finding here is, if you want to increase or improve lung function, then a LAMA is better, or in other words, an ICS improves exacerbations better than it improves lung function, and LAMAs improve or lung function better than exacerbations. So the consequence would be, if the lung function is impaired, we should add a LAMA. If exacerbations are the problem, we should increase inhaled corticosteroids or anti-inflammatory treatment. Question is, can we prove this? And we did this in a subgroup analysis where we looked at patients who had persistent airflow limitation, which was defined, as you remember from the Job-Kersten study, with patients who had an FEV1 of less than or equal to 80% of predicted. And what you can see here is, when you compare the overall intention to treat, this is getting out of battery here, if you compare the overall intention to treat population to those who have persistent airflow limitation, the numerical reduction and the statistically significantly reduction in exacerbations is higher in those patients who have persistent airflow limitation compared to those patients of the overall population, suggesting that the subgroup that has persistent airflow limitation is the one that profits most from the addition of another bronchodilator. As you can see here, this is sort of the reduction in the moderate and severe exacerbations, and this is even more marked in patients who have severe exacerbations or in severe exacerbations, which is even higher compared to the overall population. I mean, very important. This group here contains all of these patients, and this is just a subgroup of this patient population. So the advantage of this actually is that we can identify by very simple spirometry which patients may be those who profit most from triple inhalation therapy. Another important finding, which was a bit surprising for me, but I think very important for clinic because of its clinical relevance, is that, again, when patients were analyzed, at what time did the reduction in exacerbations appear most, we could show that during the winter season, when we have more exacerbations, those patients who are on triple therapy have a bigger profit compared to the summer season when there's not much exacerbations. So the big difference here actually occurs in winter month, and when we compare all patients to those who have persistent airflow limitation, this difference is even more pronounced. So patients in the winter season who receive triple inhalation therapy are those who profit most from this additional treatment. The likelihood of normalizing airflow obstruction was also identified in this, or examined, and this is a paper that Alberto Papi published from this data set. When you look at the patients in the Trimaran study with persistent airflow limitation at screening, those who received triple therapy were more likely to achieve normalization or improvement in lung function above 80% than those patients who remained on dual therapy, and the same was true for the TRIGGER study. Now, we have talked a lot about this, and I think it is not very helpful for clinicians to say we have to identify which patients might be the optimal patients for this treatment by looking at persistent airflow mutation, which of course is very helpful to do, but the question is much more in terms of looking at this prospectively is which patients actually, when put on a single inhaler triple therapy, do achieve remission. And we have discussed this morning, and I think this is very important. And this is an analysis published or shown recently at the ERS meeting in Vienna, where they looked at the results from the CAPTAIN study, which, as you remember, did not show a significant reduction in exacerbations. They unfortunately used the very stupid, for this very stupid definition of improving lung function by 100 ml or more. But even if you ask which patients did achieve an improvement in lung function of 100 ml and more, and then remained exacerbation-free and remained in remission, this was 21%. And it was 34% on triple therapy or even on dual therapy, but in triple therapy, even 43% or 47% on the high-dose fluticasone furoate umeclidinium vilanterol combination. 47% of those who were put onto triple therapy achieved and maintained remission. These are the ones who have had not an improvement in lung function of more than 100 ml, and 38% had an improvement in lung function of more than 100 ml. And we have the same data, up to 47% of patients who are put on triple inhalation therapy achieve remission, which says to me not everybody has to go immediately onto a biologic just because he doesn't or he has not received inhalation therapy. And the same is true. This is a graph that I drew, and together with Chiesi, I hope we will be able, and again together with Walter, I hope we will be able to improve this data tremendously. But what you can see here, again, when you look at the data, the patients, this is dual inhalation therapy from the Trimaran study and dual inhalation therapy from the Trigger study. At least 18%, at least on dual therapy, achieve remission with the not so good definition criteria of having also an improvement in 100 ml of lung function. So this is induction and maintenance of remission. But with this triple therapy and the caveat that they have to improve by 100%, you can see here that's 28% in the Trigger study, the patients with more severe asthma, and 30% the patients with not so or moderately severe asthma achieved an improvement in lung function of 100 ml and maintained remission. So I think this is in a very important perspective to look at this treatment, because from a clinician's point of view, this is very important. So we have this four-component definition here, plus the 100 ml FEV1 improvement. So up to 30% of patients put on single inhaler triple therapy can achieve more than 100 ml FEV1 improvement and maintain remission for a whole year. So in conclusion, if you want new evidence, is that triple inhalation therapy from asthma from a single inhaler works in asthma and is more likely to improve pulmonary function and reduce exacerbations compared to medium to high dose ICS LABA therapy. It's especially efficacious in patients who do have persistent airflow limitation despite medium to high dose ICS LABA therapy. And up to 47% of patients on high dose single inhaler therapy can achieve remission and might not be switched to a biologic, and a single inhaler triple therapy is the new option to simplify and optimize treatment adherence, because it is easier for patients to inhale from one inhaler than to have to choose which inhaler they prefer more. And with that, I'd like to thank you very much again for your kind attention.